thank you so much for asking me to come and talk to you today. This is a topic that is close to my heart. I was a consultant breast surgeon, and in 2015, I was diagnosed with breast cancer myself. I never examined my breasts. I didn't think it could happen to me, and I got stage 3 breast cancer. And immediately, I had every single treatment that I gave my patients. I thought I knew what breast cancer was like, and I realized I knew nothing. And then 2.5 years later, in 2018, I had a loco-regional recurrence on my chest wall, which meant more surgery, more radiotherapy, thankfully no more chemo. And the side effects of that stopped my arm working properly, so I had to retire as a consultant surgeon. So having spent 20 years of my life training to be the best breast surgeon I could be, breast cancer stopped that happening. And I now spend my time writing, creating videos, trying to help patients understand what is happening to them, and also helping healthcare professionals understand what patients need, because I had no idea what I really needed until I became a patient. I'm the author of The Complete Guide to Breast Cancer, and I've actually given my last book to a friend, so I don't have it with me. We're doing the second edition at the minute, and it covers, I bought 20 books when I was diagnosed as a consultant breast surgeon, because I wanted to know what the patient's story, what it was like. I was terrified. I bought 20 books. I had never been on an online forum or a breast cancer website as a surgeon. And when I did, when I was looking for information myself, I was shocked and sometimes horrified at the questions patients were asking, at the amount of information that didn't sink in when their doctors had spoken to them. And I thought, I need to do something about it. And that's why I wrote the book. And it's not just explaining all the treatments and why they happen and the questions to ask, but we talk about much what your network does: depression, anxiety, sex, relationships, the menopause, fear of recurrence, how you move on, what to eat, everything that goes with a cancer diagnosis. But one of the things that's really made me passionate about is trying to improve patients' quality of life after a cancer diagnosis. I used to tell women that the menopausal symptoms they'd get from treatment, maybe a couple of hot flashes for a few 6 months, your vagina might be a bit dry, off you go. And I assumed if they had problems that someone else would sort it out. And I said that whether it was women in their 20s or women in their 80s. And that's because as a breast surgeon, I had no training in how to handle the menopause. We had a specialist GP who did a clinic once a month. I left it all to her. My training was how to operate and how to treat people, not how to cope with the side effects. And I'd never heard anybody talk to patients about sex before. And I remember when I did bowel surgery, it was common for men, when their cancer was close to the prostate, I'd have to tell them, you may get erectile dysfunction, or you may ejaculate, but it'll ejaculate back inside. No one told me how to help those men afterwards. And it was the same with breast cancer. And it was only when I became a patient myself in my 40s with an instant menopause through chemo, and I realized, oh my God, the menopause isn't just a couple of hot flushes for some people. I used to describe it as a reverse orgasm because I'd feel it starting in my toes and working its way up. I'm going to have to strip off. This is horrible. I realized how hard it was. So when my cancer came back, I had my ovaries removed so I could go on to letrozole because I was still premenopausal. And I discovered what it's like to have no sex hormones and to never get turned on when you read a book or watch a film, and to have a permanently dry vagina, and how you cope when you have a relationship or when you don't. So I now talk a lot about how to help women understand how to control the symptoms of the menopause, whether they should use HRT or not, and how to try and get their sex life back. I've got a lot of videos about talking about all of this on my website, on Instagram, and my YouTube channel, which is slowly going up. So if you want to find more about that, just put my name, Liz O'Riordan, and you'll find access to all of that. But a thing that might really help all of you, I did a podcast 2 years ago. We've just relaunched it now, called Don't Ignore the Elephant. And in the first season, I spoke to Sam Evans. She is Sam Talk Sex, and she runs a website called Joe Divine. Sam is the queen of lube. I can talk about that. She was a nurse who used to use KY jelly and Durex lubes and got awful itching thrush. And she discovered that lubes are full of awful ingredients that can make your vagina irritated and painful and give you thrush. So she set up a sex website for men and women to help get their lives back. Some of her oldest clients are women in their 90s in nursing homes who've lost their husband but still want some sexual intimacy. They want to have an orgasm, but they don't know where to go. She's incredible. And we talk a lot about how to talk about sex, how to get your sex life back, how to start approaching it, how to help your partner understand when you just don't want it. And that's a really nice listen. And I had a lot of women listen to it with their husbands so they could hear what it's like from our point of view and understand how things may need to be different. So that's me in a nutshell, where I've been, why I know what women need, having been through it myself, and what I talk about. And I am happy to answer any questions any of you might have. But if you wanted me to start talking about sex and intimacy after breast cancer, I can start with that. Would that be helpful? Nods, yeses? Yeah, okay. So the first thing one of the first things you need to do is, if you are in a relationship, is explain to your partner that it's not their fault that your libido has gone, your sex drive has gone, you don't get turned on. because partners can find it very frustrating that what used to work doesn't. And it's almost explaining, and there's, again, the chapter in my book talking about this can often help partners understand, because of the drugs you've been given, if you're on hormone blockers, if you've had chemotherapy, your female sex hormones have dropped. And estrogen is a lubricant, which is why your vagina is dry and why it's very hard to get wet when you're aroused, and why you don't always feel in the mood when you normally would, because your sex hormones have either dropped right down or they're non-existent. You can still find your partner attractive and fancy them, but you don't have that medical urge. Things don't work. And if they can help understand that in the beginning, that can really take things to the next level. And I think one of the most important things to remember is you can have penetrative sex again, but that's not what sex is about. There are so many other things you can do. And I tell a lot of women to think about going back to dating again, almost first base and snogging on the sofa, and just remembering everything else that goes with sex and intimate massages and all the other little bits that you can still find pleasurable. So you get some enjoyment if penetrative sex is painful, because we're all focused on that's all you have to do, and it's not. There's so much more to explore. I think it can be really important to get to know what you like again, to actually masturbate again, because although your estrogen has gone, your clitoris still works. You can still have an orgasm. You can remember how good it feels, but you may find you need different stimulation. And on Sam's website, Joe Divine, there are some fantastic vibrators that you can use with air pulses and things. You may need a stronger stimulation and actually realize, yes, I can orgasm. It's actually quite a nice way to get off to sleep again. Things do work, and work out what works for you. So you know that you can still have pleasure, and then potentially get your partner to help do that with you, and kind of taking penetration off the table. But I think you have to learn what's right for you. The thing that every single girl should be told about at school is to use lubricant. I thought lubricant was what dirty girls used or prostitutes used. You don't use a lube, you should get wet automatically. It's bullshit. Sorry. Yes, I don't think you can see this in the camera. Yes is a fantastic lubricant. It's called YES. So some GPs will get it for you on prescription, but you can buy it over the counter. They do water and oil-based for vaginal and anal use. There are no chemicals, no parabens, no irritants. It's fantastic. They also do an internal vaginal moisturizer, just like a little tube and a tiny applicator you can pop up to lubricate the vagina if you are getting recurrent UTIs because things are dry. It's great. It doesn't smell. I'm going to get really messy now when I do this. Hold on. You have a look. It's just like a gloopy clear liquid. It doesn't smell of anything. It's great. Another lubricant I recommend, and I've run out of mine, is called Sutil. I'm going to type it in the chat, SUTIL. And that's another fantastic lubricant to use. They do one which has got a little bit of a goat horny weed, I think, in it, that's meant to give a bit of extra clitoral stimulation. That's really, really good. There's also a silicone-based one called Silk, SYLK. I don't like that. I find the silicone stuff tends to smear everywhere and doesn't stay where it's put. But this is brilliant. You can put it on you, you can put it on your partner, you can put it on sex toys. It makes everything slippy and slidey and gets rid of that dry, painful, it's rubbing, it's really, really sore. So play around with lube. Even when you're masturbating with yourself, it can make things really, really more fun. I think lubricant is the first thing you should think about. The next thing, I'm just going to wipe this off my hand. The next thing I want to talk about is vaginal estrogen. Now, I don't know whether any of you are taking it. As a consultant breast surgeon, I was terrified of my patients getting a recurrence. Now, HRT is a separate issue, but I would say, no, don't have anything because it might come back. And then I became a patient who was getting cycling tears after half an hour on the bike. It was a real issue. And my GP said, well, you can have vaginal estrogen. And I went, what? And actually, research has now shown that vaginal estrogen is safe. It does not increase the risk of recurrence. Now, the studies are done on women taking tamoxifen. Because it is inserted vaginally, it is absorbed into the vagina. The amount that gets into the bloodstream to potentially reach a sleeping breast cancer cell and wake it up is tiny. If you are taking an aromatase inhibitor, like I am, we worry a little bit more because you have no estrogen and potentially this is giving you a little bit, but it is a tiny amount. And doctors, especially in the States, are now realizing that women's quality of life is far more important. And we know that if you drink more than 5 units a week and you are overweight and you don't exercise, they will all increase your risk of recurrence far more than a tiny, tiny bit of vaginal estrogen. And I think it should be your choice. And you should be able to go to your doctor and say, look, I want this. I know it can help. I understand there may be a very, very tiny risk, but I'm prepared to take that to get my quality of life back. I think it's really, really important that you are empowered. Another reason that we should be able to use it is because the dose is half what it used to be. The kicker is the leaflet, you know, those leaflets inside drug packets and you always open it and it's always a drug leaflet bit first. The FDA in the 1980s said, do not give to people with breast cancer. And it hasn't been updated. So you have to forget that. And it's not just using vaginal estrogen for sex. It's for recurrent UTIs and cystitis. It just lubricates it. And it also helps reinvigorate the vaginal wall. So vaginal estrogen is fantastic. British Menopausal Society and breast surgeons have agreed that vaginal estrogen is safe for women with tamoxifen. We know there are risks with letrozole because the whole point of the aromatase inhibitors is to stop you having any estrogen, which is why the menopausal symptoms are worse and why your bones thin. And they worry that that tiny bit absorbed vaginally could potentially make a breast cancer cell wake up. But they are so worried about this, but they don't tell you, you're not allowed to drink anymore. You must exercise to reduce the risk of recurrence. God forbid we do that. We're scared about a tiny bit of vaginal estrogen ruining women's lives. And I think you could write a letter to your breast surgeon or your oncologist saying, my life is miserable. I know the dose is half what it used to be. I understand there is a small risk it might make my breast cancer come back, but I don't drink much and I'm exercising. Please, can you prescribe this for me? The traditional one is Vagifem, which is a disposable applicator. It's tiny. It's half the size of my little finger with a tiny little white pill. And when you push it in, a bit of lube, again, on the outside can help. I push it into the cervix, to the hilt, like you would put a tampon all the way in, and then I pull it back about an inch, because you actually want it in the bottom of your vaginal wall, not at the top. There's a great one that is better for the environment called Vagirux. We just type that in here. And that is, you get 2 plastic applicators and you put the tablet in. So you only throw away 1 applicator a month. A newer thing is called E-string, which is like a little coil. It's like a little coil that goes in for 3 months. Not a coil, a diaphragm that you can insert yourself. So there are different things available, but please, I'm willing to accept the risk, Mr. GP or Mrs. GP. Please, can I have the drugs? The evidence is coming. That can really help, not just for sex, but for the dryness, the irritation. I got cycling tears in my labia from doing it. It's awful. But let's say some people, their partners just want penetration. That's the thing that gets them off, and you miss it, you want to do it. How can you help? So when you aren't using your vagina, the muscles kind of shrink and contract, a bit like how you lose muscle tone when you don't go in the gym regularly, and you need to stretch it. And sometimes the thought of even putting your little finger in can be really painful. You can get packs of vaginal dilators. Now, I use a set called Inspire, but again, the Joe Devine website sells them. They're this. They're really small, they're pink and soft. There's a thing on the end to stop them getting lost inside you with a bit of lubricant, and you can use them in the shower or in the bath. And they build up, they build up and they build up to an erection size. This has got things that I'm going to explain later. So they build up. And what you can do is slowly stretch yourself. And it can really help if you masturbate whilst you're doing this, because when you have an orgasm, your vagina muscle relaxes and contracts, and you can then often get the next one in. By slowly stretching yourself, if you know that you can get this inside, then it's easier if you have a male partner for them to believe they can have penetrative sex, and for you to believe it's not going to be sore. And like a muscle, if you don't do it for a month, it can start to get tight again. So this could be something that you just do every two or three times a week. That can really, really help. Also doing it with your partner so they can kind of understand and see. Using lube, making it fun. And this is something that a lot of women do regularly. When you do have penetrative sex, I've had a lot of women say it's really painful when partners can get carried away thrusting. It's sore, and then you get tight and you push them away. And that's where these things are fantastic. I'm going to put them in here. I think it's O-Nuts. If you search that website, what these are silicone stretchy rings. They're really stretchy, and you can stack them. And what you can do is put them over a dildo or a penis, so you limit the depth of thrust to a couple of inches. But because they're tight, your partner feels they're fully inside you, but they're only going in. And that can often help make sex easier for you if you're concerned about deep, painful penetration. So there are lots of things that you can do to help. And it's kind of, sex may not be spontaneous again, but if you want penetrative sex, you can. And the more you do it, the easier it gets, because the vagina is used to being stretched, and you realize that you like it. And you may find that you do start to get wet naturally again. A lot of women find it hard because they don't have a sex drive. They literally never want it. And it may be that you need to think about putting it in the diary. A lot of partners are scared of starting it because they don't want to hurt you. They don't want to cause pain. It was awful the last time, I don't know what to do. And so they don't want to make a move. They're relying on you. And it may be you think, right, it's been 2 or 3 months. I'm going to start things. And it will feel awkward and weird, but you think, this is something I do to get things going. Because often you're not in the mood. And when you do start getting into foreplay, you get there. But it may be you thinking, right, I need to start this. The role needs to flip. So the basics of the hormone blocking. When you are premenopausal, your ovaries produce estrogen. Estrogen can feed breast cancer cells that are positive to make them grow. So once we've taken the cancer away, we want to make sure that any cells floating around your bloodstream are switched off and don't start to grow again. Tamoxifen can be given to anybody, because what tamoxifen does is stop breast cancer cells recognizing estrogen. So like, this is a receptor on a cell, this is estrogen, they normally click together. Tamoxifen kind of puts a sheet over it so the estrogen can't attach. And you can give that to anybody. So you still have estrogen in your blood, so you get the benefits in the bones, you do get some benefits in the vagina, you don't absorb as much, but you still absorb a little. If you are young and you have, say, a big cancer, doctors are worried about recurrence, they want to give you more treatment, They then want to give you the aromatase inhibitors, which are anastrozole, letrozole, or exemestane. But they can only be given to women who aren't producing estrogen, and this is why. What those aromatase inhibitors do is stop you making estrogen, because you make estrogen in your blood and in your fat from other sex hormones that are converted using an enzyme called aromatase. And they stop that enzyme working, so you don't make any estrogen at all. Now, if I give that to someone who's 20, it's going to have no effect because the ovaries are churning it out. So I'm stopping you making a tiny amount, but the ovaries are still going, hey. So you either have the Zoladex, or when you have your ovaries removed, to turn your ovaries off. And then that little extra bit of estrogen you make in your fat is being turned off by the aromatase inhibitors. So you have nothing. Does that make sense? And there are trials showing that can be for premenopausal women with a high risk of recurrence. Giving them Zoladex and exemestane can improve the survival. And this is an interesting question. I've seen this in blogs. Is it safe to have sex during chemo because I'm scared I'll make my husband's hair fall out? No, it's completely safe. What you do need to know, though, is if you are taking tamoxifen or chemotherapy, you must use contraception, because you can still get pregnant if your ovaries are working, and tamoxifen can damage a fetus, as can chemotherapy, as can Herceptin. So you need to use contraception to make sure you don't get pregnant when you're on any of those drugs. But it is completely safe. And actually, a lot of women feel really horny during chemo. And it's a way of connecting to your partner and feeling you're not alone. But no, it's completely safe. Menopause has kind of become the latest cash cow. You've got lots of celebrities who have now reached that age who are saying it's a disease, it's horrific, it's the end of the world, oh my God, what do we do? And HRT is being promoted as the panacea to cure everybody of everything. It makes life better, it stops dementia, it stops heart disease. If you're not taking it, it's the end of the world. And I get so many women with ER-positive cancer coming to me crying, I'm terrified I'm going to die of dementia. I'm horrified I'm going to get bone disease. It's a really unhealthy narrative. The truth is, most women get through the menopause okay. You don't see them. They're like on TripAdvisor. If you go to a restaurant and you have a nice meal, you probably can't be asked to fill it in and let them know. It's the people who complain and the people who think, oh my God, that was amazing, whose voices are being heard. Most women who have breast cancer and have menopausal symptoms are all right are bad for a couple of years and it settles down. But when it's young, when it's instant, it can be really, really hard. And some people just naturally struggle. And HRT is quite controversial at the moment. There are two schools of thought. There are one that believe a book written by an American oncologist called Dr. Avram Blumey, who says, we used to treat metastatic breast cancer with estrogen in the 1950s. Estrogen is safe. Everyone should have HRT. I gave it to my daughter and she's had breast cancer. It's great. It doesn't increase the risk. Now, those studies were old and they were terrible, but it did show there was a risk. There have been newer studies done looking at giving HRT to breast cancer patients, and some of them showed it did increase the risk of recurrence. Now, none of the trials are perfect, and there is mixed evidence out there. No one can definitely say HRT is 100% safe or 100% dangerous. And I think if any woman is struggling with the menopausal symptoms and she's tried all the other things that can help, and it is ruining her quality of life, and she's about to stop her breast cancer treatment, often for psychological issues, then you may want to try HRT. But you need to know it may increase the risk of recurrence. And if breast cancer comes back, it can't be cured. And that's the narrative that I don't think is coming through. Secondly, HRT is not licensed to prevent heart disease or strokes or dementia or osteoporosis. These are all small trials that have shown there may be an effect, but a doctor cannot prescribe it to stop you getting dementia. Dementia happens because you get old, and women who are old have gone through the menopause. HRT cannot prevent it. So whenever you hear these, just take it with a pinch of salt. HRT is purely given to help women going through the menopause a bit of extra estrogen. Now, if your cancer is sensitive to estrogen, most doctors would think it doesn't make sense to give you additional hormones when we're giving you drugs to stop that, because we know breast cancer cells feed off estrogen. If there's enough in the system, they might wake up and phone a friend. And to come back to that, it's understanding how breast cancer can come back 5, 10, 20 years in the future. Any invasive cancer, no matter how small, you may only have a 0.5 centimetre tumour, a grade 1 negative nodes, will have shed cells into the local blood and lymph vessels, because that's what cancers do. Now, most of those cells will float around, they don't get enough blood, they can't find a friend, they just die. Some of them may go to sleep, and they may be sleeping in your lungs or your livers or your bones. And for some reason, years down the line, they just suddenly wake up and they start to grow and they find a friend. Now, we give tamoxifen and aromatase inhibitors for 5 to 10 years, and we know the benefits of those drugs carry on for another 5 to 10 years afterwards. We don't give them lifelong because they have side effects. We know tamoxifen can cause cancer of the womb, it can cause cataracts and strokes. We know the aromatase inhibitors can cause serious bone thinning. So there's that balance, the pros and cons. The trials have shown giving them for that length of time gives you the benefit of them for another 5 or 10 years. And it doesn't make sense to me to take HRT to give yourself additional estrogen when we're giving you drugs to stop these estrogen cells waking up in the future. So it's educating women and GPs and nurses and doctors like me about all the things that can help your side effects before you go to HRT, knowing it's a last resort if you really, really need it. Does that make sense?
I just had a question. So you mentioned about the prolonged for 5 to 10 years after you stop, it used to benefit. So what happens? I think this is something that always worries me a little bit, is like, what happens then? Because I'm still young, and in 5 to 10 years we get all young, and I worry that I'm going to have that, increased risk when I finally do come off stuff. And those sleep cells, do they sometimes just die, and that's the hope, or what sort of?
Yeah, that's a great question. So if breast cancer is going to come back, and this is any cancer, triple negative, HER2 positive, they generally come back in the first 1 to 2 years, or they come back 10, 20, 30 years down the line. And that's why you're followed up with annual mammograms for the first 5 years. Your doctor sees you at the end of 5 years, because if it's going to come back, it generally comes back quickly in the first couple of years. So that's why we're really intensive, and everyone gets treatment for 5 years. We know that the additional benefit of giving you the drugs for another 2 to 5 years is worth it in women who have high risk disease. So basically anyone who's needed chemo or Herceptin is often giving it for an extended length of time to reduce the risk of those cells waking up. And the longer you go without it happening, the less likely it is. They can still wake up just because. You can do everything. You can not drink, you can eat 50 fruit and vegetables a day, you can be in the gym twice a week, and it can still come back, because there's so much we don't know. And sometimes it's getting your head around the fact, and I didn't get this in the beginning, but it helped me. My cancer comes back or it doesn't. It's 50-50. It's out of my control. I can live healthily, and I can try and live my life the best I can. And if it happens, it happens. I've done what I can to reduce it. The trials have shown if we give tamoxifen for a longer length of time, we do more harm to more potentially healthy women. And I don't want to give you clots in the legs or cataracts or strokes. And I don't want 50-year-old women to have crumbling bones because they've been on exemestane for 10 years. So this is risk balance. Plus, we know the side effects of the menopause are bloody horrible when you can't have HRT. And there is that fear when treatment stops and you think, what if? I'm coming up to it now. And it's just thinking, well, all this treatment is trying to stop microscopic cells that might be in my body. And the chances are they will be asleep. And they won't wake up, they'll just die. But that's why it's also important that everybody knows what the symptoms of recurrence are. And if you get a weird cough or you feel a bit sick or there's something new, you need to go and get it checked out, even if it's 20 years in the future. And it's really scary. But generally, if you make it to 5 years, we all kind of breathe a sigh of relief and think, well, the chances are you'll die of something else. Does that help? It's scary to talk about, but that fear is always there. And I think the problem is social media is often full of a lot of young girls who've got metastatic breast cancer because they're talking about it. You don't see all the women who have moved on, who are living healthy, long lives, because that's boring. They've moved on. They're not seeing that. You're only seeing a very small account. And when you follow breast cancer people and they die or it comes back, I have to step back every once in a while because it's too much. I don't want to see, because it's stirring all these things up. You're not seeing the whole picture of everybody with breast cancer of your age at the minute. You're seeing a very small snapshot. And it's fine if you want to unfollow a load of people or switch it off for 2 or 3 weeks to protect your own sanity. That's really, really important, because it can be a really weird world out there. Remember, you're only seeing a tiny snapshot. There are many, I've seen young women with horrific disease who have lived for 30, 40, 50 years. An old woman with a tiny cancer and it came back 2 months later. There's so much we don't know. All you can do is live your life the best you can, have fun when you want, and accept it's kind of out of your control now.
It's really scary. So I'm going to get all upset. So it's the first time I've talked about it, really. Like, went, from no lumps and bumps to, routine mammogram. Thank God for those. So I've told everybody, like, if you get a call from mammogram, please go. Yeah. And gosh, that's going to be nice and painful when I go. People moan about having mammograms being painful. God, when you've got half your boob missing, that's going to be interesting. Yeah. But I'm just really, so I had they found 3 lumps. So I've got the HER2 positive plus estrogen positive plus another.
Yeah.
And I haven't, I'm deliberately not trying to think about it, but I'm really scared. So I've got my first yearly mammogram since, so that's coming up in a month. And I'm really, they'll be gentle, won't they, with me? Because I'm still really sore.
Yeah, well, so the scanxiety is something I didn't get. When you get that letter for your mammogram, or you have to go back into the breast clinic for whatever reason, it's almost like post-traumatic stress disorder. The scanxiety is real. And I tell my husband, I'm going to be a nervous wreck for the next 6 weeks because I'm worried about it happening. And then it happens. And then I'm worried for the next 2 or 3 weeks until I find out. Except you're going to be like this every year. It does get a bit easier in time and you may worry a bit less, but this is going to happen. Tell your family, I'm going to be a nervous wreck. Please bear with me. It's irrational, but everybody feels like this. Mammograms are generally less painful because your breasts are less dense because you've been on hormone blockers. Generally, so that your breasts are softer. I found my first one was quite sore. The next one wasn't so bad, but again, it's just a pinch. The mammograms are looking for local recurrences or new cancers in the other breast, and they happen in about 3 to 5% of women. It's a rare thing to happen. Almost every follow-up mammogram is normal. They're just doing it to make sure there's not another cancer that's going to grow. So the chance of them finding something is really, really small. But just to say, I'm going to be a nervous wreck. This is going to be horrible. Try and don't put your phone in your bedroom so you can't look at metastatic blogs in the middle of the night. Just accept. Try and lower your workload or just make your life a bit easier when you are waiting for a scan. So I've had a couple of scares. And, you know, you wait a couple of months at home and do I tell the GP, don't I? And I do. And when the GP says, right, I'll send you in, I go, holy fuck, they think it might be something. Now I'm really worried. And then when I have the scan, it's almost like a breath of relief. Oh, it's been done now. The results are out of my hands. I just have to wait and see. The mental roller coaster that could kick in 1 to 5 years down the road is real. So it's normal to feel like this. I'm hoping it won't be as sore as it was. Just accept it. This is normal. It's okay to feel like this. There's no easy way to get around it.
I just want to get on with my life, but I can't because I'm still having my nosebleeds, and because I look normal. You know, people think, you know, oh, you look really well, and I'm, you know, I put on a brave face, but I'm not well, and I've been through it. You know, I've got my still got nosebleeds, like every, you know. Yeah, it's.
I think that's why having a support network of women who've been through it, you can moan and rant to, because your family won't get it. They want to move on. They think you look great. You don't have to tell them how shit you feel in and outside your head. That's why for me, having a group of women with breast cancer, I could talk and rant to God, my husband doesn't get this, or don't do that, because we understand. And then you accept the rest of your family have no idea, and you don't want them to, and life does have to carry on. We could have, you know, different chronic illnesses, things that you're living with. Life does have to carry on, and you'll get these wobbles when you have a scan or something, and then time is a great healer. And I didn't believe this when I was diagnosed, but 5 years on, I finally don't wake up every day thinking, is today the day my cancer comes back? I can put it behind me, but it took time. Again, social media, it's everywhere. You have to give yourself time. And sometimes the reality of your cancer treatment doesn't hit you until you finished chemo and Herceptin. And the doctors say, goodbye, see you in a year. Think, what? But you've seen me every week for a year, and what happens now? And it takes a long time. You're not alone. What you're feeling is normal. When friends say you were right, you either say, what version of fine do you want me to tell you today? Or just accept. They don't need to know. They may have their own shit going on. You know, their kids got mental health issues. You know, we're all fine. But you'll have true friends you can moan and whinge to when it's right. Does that help? Everybody feels what you're feeling, but we don't really talk about it. Content for my next video. I want to talk a bit about the symptoms of the menopause. So again, I'll send Vicky a link. The British Menopausal Society has a great PDF of alternatives to HRT that you can print off and take to your GPs and your breast surgeons if they're clueless. We know, so they're mainly for the hot sweats and the night flushes, which are like tiny micropulses of estrogen that just make you go, and they're horrible. I didn't sleep for 3 years. I was waking up every night. Top tip, separate duvets if you share a bed. We have 2 single duvets on our bed, so I can toss and turn with my thin summer duvet, and my husband has a thick winter one. Life changer. Plus you can bung them in the washing machine when they're sweaty. Little things like this. Some people sleep in sports clothing because the sweat dries easily. I can't be doing with that. I have to be naked. I can never share a room with anyone again, but you'll find your way. But separate duvets can really help. Some of the drugs that control the hot flushes and night sweats have other purposes. So the commonest ones are antidepressants, anti-epileptics, and very strong painkillers. And when a GP says, I'm going to give you an antidepressant for the hot flushes, women think, he thinks I'm mad. I'm not mad. This is real. It's because they work in different ways. So there are drugs like venlafaxine and citalopram that can help with hot flushes. Again, this will be in the list. There's a heart drug called clonidine that can help with hot flushes. There are some painkillers like pregabalin and gabapentin that can also help with the hot flushes and the night sweats. The simple things, the boring things like exercise. When I exercise really hard, I sleep through the night. I don't wake up from the sweats, and that can actually help release things. You may have triggers like alcohol or spicy food, and you'll kind of learn, I can't drink alcohol again. I'm right back at chemo hangovers. My night sweats are really, really bad. You may learn your own triggers. Good sleep patterns, trying to go to bed early, just training yourself. And those things can really help, as well as complementary therapy. I tried acupuncture and I tried hypnotherapy. And actually CBT, there are some practitioners who do counselling to try and help you when you have a hot flush. Just try and think of something else to divert what you're feeling. There are all sorts of things that you can try. It's just most doctors don't know about them. And I hate the fact I'm swallowing 5 drugs to help me cope with the side effects of 1 drug. It just doesn't make sense. But there are things you can take, and they're trial and error. So I'll make sure I send that to you. So if you want help, you can educate your GP. Did you know these can help? Can I try one of them, please? If you are really, really, really struggling, it might be worth talking to your oncologist or your breast surgeon about a treatment break. Because sometimes for some women, coming off tamoxifen for a month can just give them a breather and then reset again. It may be worth, could you try reducing the dose? And actually for some women, we may stop it. We use an algorithm called Predict that puts in all your specific tumor details, your age, how it was found. And that gives us the benefit of hormones, chemo and Herceptin for you for a recurrence in the next 5 or 10 years. And if you've been on it for 2 or 3 years and you're still struggling, we may go into the computer and say, well, actually, it's only a 2% benefit. It's only keeping another 2 women in 100 alive at 10 years. So if you're really struggling, you could stop it. You have to accept, yes.
Sorry, I was going to say, what happens if the Predict tool is not really very relevant for you? Because when I had my details put in, it looked like the bed very low. But when I had this test called Prosigna test, it showed that benefit and that Predict tool was not really applicable to me. And the oncologist, because of my age and things, it's for older women. So it's hard for me to then know all of these statistics because they don't.
It is, yeah. So PREDICT is based on studies that have looked at hundreds of thousands of women. And because breast cancer is mainly a disease of women in their 50s and above, most of the data relates to women in their 50s and 60s and above. It's also, they haven't looked at women who've had chemotherapy first. And a lot of young women have chemo first. So PREDICT is a basic guide, but it's not accurate if you've had chemo first. The future will be precision medicine, where hopefully every woman will have a test like Oncotype or Prosigna just to see. Because we know there are women with a very, very low risk of recurrence, and it can come back and they're dead in a year because of stuff we just don't know. And that's why especially the younger women are potentially being offered these tests to try and work out, actually, do you really need chemotherapy? Do you not? And if you're young, we always try and persuade you to stay on the treatment if you could. If you are older and maybe, well, actually, you're 65, you're 70, the benefits are smaller for you compared to someone who's 20 or 30. There's just so much we don't know. It doesn't obey the rules. I hate this disease. It doesn't make any sense at all. And again, I could tell you, you have a 90% chance of it coming back. And you may think, oh my God, that's awful. But if you're the 1 in 10, and you live until you're 90, you've potentially had 90 years of worry. There's no way of knowing which group you're in. So I try and say the numbers can help. The numbers help doctors guide whether you need chemo or Herceptin or how long you need hormone blockers. And they give you a rough guide as to your chances of staying alive, but nobody knows, because for you, it's 50-50. And you either think, this is the end of the world, I'm going to die of breast cancer, there's no point living. And often it comes back in people who are pessimistic. You just kind of go into this negative space, or fine, I've had it. I've had the best treatment I can have. All I can do is live my life and accept there'll be wobbles and bumps along the road. And I can say that now, 8 years down the line from my first breast cancer. If you'd asked me 6 months after it, I'd have said, oh, don't be stupid, I'm terrified of it coming back. I'm going to be dead in 3 years. What's the point in planning? And it's just this, hopefully this roller coaster you'll go through, that as life goes on and your cancer doesn't come back, things just soften and the bumps get smaller rather than this fear. But the mental side of it is really hard, and we don't talk about it enough. Chemo causes brain damage. Even now, I cannot do anagrams in cryptic crosswords and I still get words confused. I'll call this a potato and ask my husband, pass me the potato. And I know it's not a potato, but my brain just can't go there. It's a challenge. And it's hard to know, is that just the natural menopause happening? It affects every part of your life. And that's why having groups where you can talk and realize you're not alone and everyone goes through it. And it's shit that there's nothing to help us with the side effects of the treatments to keep us alive. It's really, really hard. But I think there is help for the menopausal symptoms without HRT. The basics: exercising, eating well, sleeping, cutting down alcohol. The list of tablets you can ask your GP for. Everyone should be given vaginal estrogen. Everybody should use lube. You can have a sex life again. It may be different. And another thing to consider, I know I've had quite a few women, their male partners were so scared of hurting them that they could no longer get an erection. And it may be they need to talk about having Viagra just to help them get over that mental block of hurting you. And we don't talk about sex with our partners, let alone our GPs or our doctors. And when do you have that conversation? But actually having that brutally honest conversation. Things are going to be different from now on, because this is what's happened to me. What can we both do so we both get pleasure? You give me a massage tonight, I'll give you this tomorrow. Just taking it back so you're more intimate in the day, just holding hands on the sofa, just as a way of connecting again, just to build that up. It's really, really, really hard. Because you've got all the body image issues as well to consider as well, haven't you? Scars and things. And I wouldn't let my husband see me naked for 6 months after my mastectomy, because I couldn't look at myself in the mirror below the neck down. And he says, I love you. Well, you're going to say that, you're my husband, but I don't like how I look, so stay away. It takes time. And you can't take any of this in when you're diagnosed, because you're still going, oh my God, I've got cancer.
Can I ask you a question? So I haven't actually really spoken to anything. So underwires bras, are they there for you? They are.
No, they're not. I hate this myth. Bras are safe. Bras do not cause cancer. Underwire bras do not cause cancer. Sports bras do not cause cancer. They say, the idiots, and I've got a video coming on this later, the underwire bra causes compression on the breast tissue, which can cause lymphedema and swelling and block things up. Bullshit. Breast cancer happens when cells get genetic changes, and if they happen in the right time, at the right order, it becomes a cancer. It's got nothing to do with compression of the skin and the fat of the breast. You can wear them about 6 weeks after your breast cancer surgery if it's not painful, completely safe. But most women don't wear the right size bra. Most women have too small a cup size, it doesn't fit, and that's why underwire bras are painful, and everyone wants to throw them off in lockdown because they're the wrong size. That's the problem with social media. Yeah. You get someone with 1 million followers post a video, like there's an idiot in America saying 70% of cancer is due to food, and fructose is a poison and we shouldn't be eating fruit. And think, oh, Jesus Christ. But people believe it because it sounds simple. It's like the turmeric enemas, or have you tried this, or CBD oil will cure you. If this stuff worked, your doctors would give it to you for free. Yeah. And we don't mention it. True. There is no cancer diet. There is no one thing that can stop it coming back. There's no magic cure, sadly. You do what you can, you live the best you can. To me, it's 80-20. I'm about to come over. The World Health Organization suggests that a cancer diet is a healthy diet. So ideally, fruit and veg. They say 30 fruit, veg, nut, seeds a week, because 5 a day is hard to do. Mainly fruit and veg with non-processed foods. You're kind of cooking all your meals yourself. A basic, normal, simple diet that seems hard work because you want to have a McDonald's. There is no magic, because if you do that, you get all the minerals and supplements that you need from the fruit and vegetables you're eating. The only supplement you may need is maybe a general multivitamin if your diet isn't great. And if you're on an aromatase inhibitor, you probably should be having a calcium and vitamin D bone supplement. You do not need anything else. But doctors don't tell you, because we think cancer patients aren't looking for a cancer diet because they know how to eat healthily. And then I go on Instagram and think, oh my God, it's ridiculous the diets people are saying. And most of the diets, the vegan juicing diet or the alkaline diet are actually working because people are having a lot of fruit and vegetables that they weren't having before. And because they feel better, they're probably exercising better and feeling a bit healthier. And it's not the diet per se, it's they're actually eating properly. But it's 80-20. I will still have a glass of bubbly when I go out, and I'll have cake. I enjoy myself. I've had cancer, sod it. I'm not going to be a pure, clean living person. I'm going to enjoy myself and really enjoy myself when I do. And if I want 3 glasses of champagne 2 or 3 times a month, then I will do. I'm not drinking it every night. I'm not having cake every night. You've got to have fun because life is short. It's exhausting to try and be a green goddess. You don't need to. Oh, by the way, my memoir is coming out in July called Under the Knife, Life Lessons from the Operating Theatre. I talk about what it was like to train as a female in a man's world, and my own history of depression as a cancer consultant, and then my own story of having breast cancer as a cancer consultant. I'm going to put the link in here. I get told off by my publisher for not mentioning it. You can pre-order it now. Under the Knife, it's called. 3 words to summarize a good breast cancer. Oh, this is really interesting. I had to have a second opinion when my cancer came back about a trial, and it made me think, who do I want to see? Because I know everybody. Do you want to see someone who puts up pretty pictures at a conference of their beautiful handiwork? Or do you want to see someone who can operate tomorrow? Or do you want to see someone who's friendly and huggy and can do all the there, pat on the head? What matters to you? What makes you think someone is good? Most surgeons will do the same operation. Breast cancer isn't complicated. We're just removing fat. It's what is important to you. And what you may think is a good surgeon, someone else may think it was awful. It may simply be, I want a woman, I don't want a man. And often you may see one doctor and then have another doctor and then another doctor because we're all busy and we move around. If you ever do have a second opinion, you need to think about, you want someone to tell you what you need to hear, not what you want to hear. Because if you want someone to tell you what you want to hear, like, yes, you can drink a bottle of champagne a night, you may see 7 or 8 opinions until you find that one doctor that will tell you what you want to hear. I think it's someone that you trust and that you get on with and that you can be open and honest to. To me, that's what a good surgeon is. But that may be different for other people. Thank you for coming on. Has anyone else got any other questions before we have to end this? Well, I hope I'm able to help explain things a little bit. And if you want me to come back and do other topics, I'm happy to do that for you, Vicky.
No, that's been amazing. Amazing. Thank you, Liz. It's been very informative, and there's lots of information in there.